Hello everyone, welcome to the webinar on the new Adult Immunization Status HEDIS measure. My name is Mike Broughton and I am Senior Corporate Relations Lead at NCQA. I want to thank everyone for taking the time out of the day to join us for an informative session on an important topic. I will be moderating the Q&A component at the end of this webinar. Please enter your questions in the chat box within the WebEx application or email them to donorrelations@ncqa.org, and I will relay them to our experts during the Q&A session. I want to remind our guests that this webinar is for informational purposes only and will not convey any CME or other educational credits. I'd also like to thank Pfizer for their generous sponsorship. Hosting today's webinar are Catherine Sobel, Senior Healthcare Analyst, and Lindsay Roth, Senior Research Associate. I'd like to hand it over to them now to start the presentation.
So good afternoon, everyone. My name is Kat Sobel. I'm a Senior Healthcare Analyst in Performance Measurement here at NCQA. And we want to start out first by providing an overview of HEDIS and data reporting methods for our current measures. Then Lindsay and I are going to describe two new HEDIS immunization measures and what the next steps are for these measures. Finally, we'll have a Q&A session moderated by Mike. So NCQA develops clinical quality measures. For example, NCQA developed the Healthcare Effectiveness Data and Information Set, abbreviated HEDIS, to measure how well health plans are performing in important areas of care. NCQA also takes those measures and puts them to use in programs such as health plan accreditation. HEDIS is widely used, which allows comparison performance across health plans. And currently about 190 million people are enrolled in health plans that report HEDIS data. Whenever NCQA develops measures, we have to make sure that the measure meets certain criteria. We want to make sure that it is relevant, scientifically sound, and feasible. We want to make sure the measure is assessing a process or event that can actually lead to meaningful change, and we want to see some kind of variation in performance. So, for example, geographic variation in performance or potential room for improvement. We also want measures that are evidence-based and provide results that assess what we are trying to get to accurately, meaning the results are valid, and provide results that are reliable or repeatable. It should also be feasible to collect the information. We need to communicate clearly what information we are looking for the measure. We also need to be careful about the burden of data collection as we develop measures. NCQA also has a well-established audit system for verifying and checking results. So NCQA selects and develops measures based on the criteria we just discussed, for example, evidence and a potential quality gap. Whenever we develop new measures or propose changes to existing measures, we seek feedback through public comment. When we introduce a new measure, the measure goes through a first-year analysis to determine if it's ready for public reporting. We then review data and work with our expert panels to evaluate whether the measure is working as expected before deciding whether to report publicly. Our measures are then put to use in programs, and all of our measures are evaluated and updated periodically, so for example, after a guideline update. So before we get into the details of the new measures today, I'd first like to give an overview of NCQA's current and future data collection methods for quality measurement. Currently, there are a few traditional approaches to collecting data for HEDIS. There is the administrative method, which is based largely on claims data, and the hybrid method, which uses administrative data and a random sample for medical record review. On top of these data sources, plans can also use supplemental data to get information on their patients, for example, from immunization registries. There's also data collected through surveys such as CAHPS and the Health Outcomes Survey. There's also a growing interest in electronic reporting. So NCQA is starting to use what we refer to as electronic clinical data systems, or ECDS, which is the use of standardized electronic clinical data. Health plans can actually use several electronic data sources to report ECDS measures, which include claims, electronic health records, health information exchanges, registries, and case management systems. So NCQA's next steps in advancing quality measurement will be through building measures to use richer clinical data captured in standard formats and expressed using machine-readable logic. Making use of richer clinical data would then allow us to have measures that move beyond things like visit counts to create more meaningful measures. And then as programs adopt these measures, we plan to harmonize our specifications and measure concepts across various programs. And finally, with implementation of these better measures, ideally we'll have better accountability at all levels of the healthcare system. NCQA currently has a variety of immunization measures covering different age ranges and vaccines and reported using different methods. The two measures that we'll be discussing today are new. These measures were added to the HEDIS 2019 health plan set, meaning that they will be using data from calendar year 2018. Both of the measures we're going to be discussing today are specified for ECDS reporting. Now, immunization measures are relevant for electronic data reporting because they can capture vaccines given outside of the provider setting. So, for example, vaccines that are given to people at retail pharmacies or at health fairs. And before describing the new immunization measures in more detail, I want to explain NCQA's rationale for developing these particular measures. Both the adult and prenatal immunization measures are based on guidelines from CDC's Advisory Committee on Immunization Practices, or ACIP for short. ACIP recommends 4 types of routine vaccines for adults ages 19 and older, including flu, TD or Tdap, herpes zoster, and pneumococcal vaccines. ACIP also specifically recommends the flu and Tdap vaccines for pregnant women. And from looking at the literature, we know that there are gaps in care for how often adults and pregnant women actually receive these vaccines. And given that stakeholders were therefore interested in quality measures that could be useful in helping to address these care gaps. So NCQA received funding from the Federal National Vaccine Program Office to develop 2 new immunization measures to assess how often health plan members are up to date on these vaccines. And we developed these measures in accordance with NCQA's measure development process. We consulted with external expert panels, we developed the measures based on clinical guidelines, we tested the measures with health plans, we sought feedback through public comment, and we made iterative edits to the measure specification as needed throughout the process. So first, we're going to review the new adult immunization status measure. This measure assesses the proportion of adults up to date with routine vaccines recommended by the Advisory Committee on Immunization Practices, and there are a few rates within this measure. A rate looking at the influenza vaccine, a rate for tetanus and diphtheria, herpes zoster, the pneumococcal vaccine, as well as an overall composite rate looking at how many of the possible recommended vaccines above were actually administered. This measure is intended for reporting by commercial, Medicaid, or Medicare health plans. So looking in more detail at the measure rates, the influenza rate in this measure looks at the proportion of adults who received an annual flu vaccine. The Tdap rate looks at the proportion of adults with a Tdap or TD vaccine in the last 10 years. The zoster rate looks for the proportion of adults who received either 1 dose of the live herpes zoster or 2 doses of the recombinant herpes zoster vaccine since age 50. The pneumococcal vaccination rate in this measure looks at the proportion of immunocompetent adults who had received 1 of each type of the pneumococcal vaccine, the polysaccharide and the conjugate vaccine, at least 12 months apart since age 60. Then to calculate an overall score for the measure, an overall assessment of how up-to-date the adult population is, we look at how many members there are and how many vaccines should be administered to those members. So in this case, in a hypothetical Medicare plan, there are 4 vaccinations, and this health plan has 3 members. And then we define a numerator based on how many vaccines were ultimately given. So in this case, our Medicare plan's members received 7 immunizations out of a total 12 for a score of 58%. Similarly, for a fictional commercial or Medicaid plan, we have 3 members, but after taking into account which vaccines they're eligible for due to age, they're only eligible for 8 instances of these vaccines. And ultimately, these health plan members received 4 of the 8 vaccines for a score of 50%. So now I will turn it over to Lindsay.
Great, thank you, Kat. Hi everyone, I'm Lindsay Roth, a Senior Research Associate in Performance Measurement and part of the team that helped develop our new immunization measures. So today I'm going to describe the prenatal immunization status measure, and then I'll end by describing our next steps for implementation of these new measures. So we developed a new prenatal immunization status health plan measure for HEDIS 2019. This measure is also based on ACIP immunization guidelines for pregnant women, and this measure is also collected using the electronic clinical data systems reporting method. The prenatal immunization status measure assesses the percentage of deliveries during the measurement period where women received flu and Tdap immunizations during pregnancy. And this measure is included in HEDIS for commercial and Medicaid plan reporting. This prenatal immunization status measure has 3 rates. The first rate assesses the percentage of deliveries where women received a flu vaccine between July 1st of the year prior to the measurement period and their delivery date. The second rate assesses the percentage of deliveries where women received a Tdap vaccine anytime during pregnancy. And there's also a composite rate assessing the percentage of deliveries where women received both a flu and a Tdap vaccine, meaning that they were compliant for both of the other 2 indicators in the measure. The composite scoring for this measure is different than the scoring method that we used in the adult immunization measure. So in the prenatal measure, we use an all or nothing composite construction. And to illustrate that method, this slide here shows a fictional commercial or Medicaid health plan with 3 delivery events in the denominator. However, only one of those deliveries was compliant for both the flu and the Tdap rate. So this health plan's performance is 33%. We felt that an all-or-nothing approach was more suitable for this measure because it's an event-based measure that's based on clinical guidelines recommending both of these vaccines for each pregnancy. And stakeholder feedback really supported an all-or-nothing rate given the importance of both of these vaccines for both mother and baby. So now that we described how we constructed the new adult and prenatal immunization measures, I'll talk about putting these measures into use. Both measures are currently included in HEDIS as first-year measures. So health plans will have the first opportunity to report these HEDIS measures in June 2019. NCQA has a process for evaluating first-year results of all new HEDIS measures to make sure that they're working as we had intended. And in our first-year analysis, we focus on several things. We evaluate whether there are changes we may need to make to the technical specifications after rolling the measure out to a wider population of plans. And then we also assess whether the measure appears to be feasible for plans to report and whether the data are showing that there is a gap in performance that a measure could help address. So once we can demonstrate that the measure is meeting these criteria, we can then recommend the measure for public reporting. And this process involves seeking approval from NCQA's Committee on Performance Measurement to publicly report performance rates for benchmarking or for use in programs. For the new HEDIS immunization measures, health plans can report them for the first time in June 2019. We'll analyze the first-year results this summer. We'll discuss the results with our measurement advisory panels. And then the earliest that we would present the results to the Committee on Performance Measurement would be September 2019. And then the earliest that the measures could be publicly reported if they were approved would be for HEDIS 2020. However, I do want to caution that sometimes we want to analyze more than 1 year of results before recommending measures for public reporting. These 2 immunization measures are reported using the HEDIS ECDS reporting method, and at this time, all 6 of our HEDIS measures that follow this reporting method are not yet publicly reported. After we rolled out this new ECDS reporting method several years ago, we've really been focused on actively building support for it and increasing health plans' uptake of electronic measures. We've been analyzing the HEDIS data each year for ECDS measures, and we have seen increased reporting of these types of measures as plans have had time to build up their data systems and establish processes for sharing data among providers, plans, health information exchanges, and registries. So we are getting closer to moving the electronic HEDIS measures into public reporting, but as of now, no ECDS measures are publicly reported. There are also other external programs that could be interested in implementing these measures. For example, programs that have implemented other HEDIS measures include the Medicare Star Ratings Program, the Medicaid Adult and Child Core Sets of Measures, and others like that as well. And each program has its own process for approving implementation of measures. So NCQA works directly with specific programs on stewarding measures through their processes. In summary, in the immediate and longer term, we'll be focusing on encouraging health plan reporting and uptake of these measures and ensuring successful implementation in HEDIS and potentially other reporting programs. So that concludes our presentation for today, and I will turn it over to Mike to open it up for Q&A.
Thank you so much, Lindsay and Kat. That was a great presentation. We do have some questions coming in over the chat. The first is the shortage of the shingles vaccine affecting rates?
Yes, thank you. So in our adult immunization status measure, in the zoster rate within that measure, we actually allow receipt of either type of zoster vaccine to count in the numerator. And we do this for several reasons. So first, we understand that it may take some time for clinical practice to transition from providing the older live vaccine over to providing the new recombinant vaccine, and also recognizing that there has been a shortage of the new recombinant vaccine.
All right, and we have another question. I'm concerned that some people will be listed as non-compliant for the pneumococcal rate because the measure requires 1 year between the pneumonia 13 and 23 vaccines, when in fact a shorter time frame is not clinically wrong.
Right, that's a great question. And I understand that the pneumococcal ACIP guidelines are a little more complex compared to the guidelines for the other types of vaccines. So I can talk through what our rationale was for how we specify the pneumococcal rate. So ACIP has pneumococcal guideline recommendations for 3 different groups of adults. The first group of adults is the immunocompromised, and this includes people with immunocompromising conditions, and they are indicated to receive a conjugate vaccine at 19 years or older, and then 1 or 2 doses of the polysaccharide vaccine between ages 19 and 64. In our measure, we actually excluded this group from the measure because the intent is to assess administration of routine adult vaccines. The second group of patients is the immunocompetent, and for these patients, ACIP recommends a conjugate vaccine starting at age 65 and a polysaccharide vaccine at least 12 months after that. So we specified in our measure the denominator to be age 66 and older, and this allows time for providers to administer the conjugate vaccine at age 65 and then the polysaccharide vaccine at least 12 months after that, when patients would be 66 at that time. And then finally, the third group is the immunocompetent at-risk population. And this includes people who have conditions that may put them at higher risk for pneumococcal disease. So this includes things like smoking status, diabetes, heart, lung, or liver disease. And ACIP guidelines recommend providing the polysaccharide vaccine once the condition is known, then the conjugate vaccine at age 65, followed by another polysaccharide vaccine at least 12 months after that, and at least 5 years after the first polysaccharide vaccine. So to accommodate this group, we specified the measure numerator to look for at least 1 polysaccharide and 1 conjugate vaccine at least 12 months apart at age 60 or older. And we selected age 60 as the starting point based on expert panel feedback that these conditions tend to develop by that age. And this is really just an example of how in a quality measure, we have to balance precision with feasibility. So for example, we could try to specify the exact timing for all 3 of these age groups in the measure, but that's, there are reasons why that is burdensome, and we might not want to do that in a quality measure. An example too is that it's really difficult to identify data on patient smoking status. So we're just really trying to balance feasibility with precision.
Great, thank you. How are performance measurements taken into account to address the immunizations that cannot be given because of contraindications?
Yeah, so we typically exclude patients from our HEDIS immunization measures if they've had a previous adverse reaction due to vaccination. So in our childhood and adolescent immunization measures, both of these measures are claims-based measures, and we exclude members if there are claims codes indicating that they had a previous reaction to any type of vaccine. But since the new adult and prenatal measures are in our ECDS reporting domain, we can be more specific and actually use SNOMED codes that say that identify whether a member had a previous reaction to a specific vaccine type, rather than just blanket excluding members with any type of previous reaction. And the way that we do that in our new measures is rather than exclude everyone if they had any type of previous reaction, we give the plan numerator credit for specific rates if the member had had a previous reaction to the vaccine in that rate. So it's just a slightly different way of accounting for vaccine contraindications than what we do in the childhood and adolescent immunization measures. But I also did want to note too that these contraindications are pretty rare, so it shouldn't have a lot of impact on the performance rates, and it is something that we're interested in looking at through the first year analysis as well.
Awesome, thank you. Can you go into the exclusion criteria of this measure a little bit? We have a question about that.
Sure. So in our adult immunization measure, we do have several exclusions. We exclude members that have had chemotherapy during the measurement period, also those that have had a bone marrow transplant during the measurement period. We also exclude members that have a history of immunocompromising conditions, and also conditions such as cochlear implants, anatomic or functional asplenia, sickle cell anemia, or cerebrospinal fluid leaks anytime during their history through the end of the measurement period. And then finally, we exclude members that are in hospice during the measurement period.
Thanks. And follow up to that, why are cochlear implants excluded?
Right. So that is one of the conditions listed in the ACIP guidelines for pneumococcal vaccination. So patients that have cochlear implants fall into that immunocompromised group of patients that we are excluding from the measure.
Thanks. Will you be submitting the composite for consideration as part of the upcoming Medicaid core set?
Yes, so we are currently exploring potentially submitting the measures to the Medicaid core sets. Right now we're working with other stakeholder groups and thinking about how to actually incorporate our HEDIS ECDS reporting method into a reporting method that states can use to report these measures. We understand there's a lot of variability across states. For example, the viability of state immunization registries. So that's one of the things we're thinking through before we submit the measures.
Will data be collected from both pharmacy and medical claims data, and that data combined?
Yes, so for these measures, claims can be generated by retail pharmacies and minute clinics for vaccinations and then shared with health plans so that health plans can capture vaccines that are given in those settings.
Can you explain the ECDS methodology a little more?
Sure. So when plans report ECDS measures for HEDIS, they specify the data sources that they're using to identify each component of the measure. For example, health plans would report, X number of members met the numerator for this particular rate, and also indicate that data was derived from an immunization registry. So we provide for the ECDS measures 4 categories of data, and also there's a hierarchy. So first, health plans would report data that they accessed from EHRs. Then they would look for data from health information exchanges or clinical registries. Then they would look for data in case management systems. And then finally, they would look for data from administrative claims. So NCQA actually has the opportunity to analyze performance rates by data source, and we can see how performance rates compare when plans use, for example, only claims data versus plans that are using data from claims, EHRs, and registries. And again, that's one of the things that we'll be analyzing during our first year analysis of these measures.
Great. We look forward to how these measures are going to play out in the future. So that's about it for questions in the chat. So I want to thank Kat and Lindsay for preparing for this webinar and presenting this webinar. It was extremely informative, and thank you both very much.
Great. Thank you.
Thank you.
Thanks everybody for coming. This was a great presentation, and I hope everyone enjoyed it. Take care.